Good afternoon, everybody. Hello. Yeah, we'll get some. Welcome, everybody, to the last session proper of our 11th EuroELSO Congress. We've got three speakers. We're going to take them in turn. First up is going to be...
Yes, so it's my great honor to introduce the first speaker, Karagiannidis from Cologne, Germany. And the title is ECMO in COVID has opened my eyes. So it's a good opportunity to congratulate on your career with your eyes shut before COVID.
Okay, thank you very much. Maybe we can close the door. It's a little bit noisy outside, if that is possible for you. So what opened my eyes, and I guess we are all happy that COVID is over now, but it's, I guess we have some learnings from the pandemic, and I will try to guide you a little bit of what I learned. And in Germany, we drew some conclusions out of that. So first of all, these are my conflicts. And if you remember, the waves were a little bit different across the world, and that were the first 4 waves in Germany. We still have some patients on the ICUs, usually transplanted patients or severely immunocompromised patients, but nowadays it's not really a problem, and it is like any other viral infection. So what was my first learning? And that was very interesting. I like this, one of the first publications from from Paris very much, because you have a lot of information in this first response to the first wave in an unknown setting in the pandemic. And there were 1 or 2 eye-openers for me. The first one was that even if you are in a pandemic situation, and even if you don't know what is, the colleagues in Paris reserved some ECMOs for patients without COVID. Yeah, that is very important that you, from the beginning on, that you think also of the other patients, and you see it here that they always had such a baseline where they reserved something for patients, for example, with heart failure. The second very important point, and you will always see now an eye for me, that's my eye-opener, and you know that I'm always interested in resources and healthcare resources and improving outcome if you have good resources. That was my first eye-opener after the first wave, that if you have a high experience, and they measured that by caseload before the pandemic began, it was more or less than 30 ECMO runs, you see, even it's not randomized, but you see a huge difference in outcome of the patient. And that was something, I mean, we discussed that extensively in the last years. We discussed that extensively in the German guidelines. And if you have a major experience, if you have a caseload of 30, I don't know the number, but the outcome is definitely better. The second point, and we discussed that all over the waves, and we had several data on that, is how long should you wait? Yeah? And how early should you initiate the ECMO therapy? And this came out not only from this study from Paris, but also from other studies afterwards. If you start early with the therapy, it seems that the patient profits most. That was an analysis from the EuroELSO registry showing the same, that those one, and you know this group A1 was a group with a high load or with a good experience before the pandemic, had a better outcome than those centers who started with ECMO in the pandemic. That was the worst outcome, but maybe it's not so bad. So it's I didn't want to judge that. I only want to say that if you have a long experience, the outcome would be better. The second eye-opener to me was what is if you deny ECMO? Yeah, that is something you have to discuss. And I guess the stress in such a pandemic situation, it was also the first wave, is much higher than we usually have, and we usually discuss if a patient can go to ECMO or not. And for me, it was impressive. Of course, if you deny ECMO for whatever reasons, the mortality is low, but the mortality is not 100%. Yeah, that is also something which we have to take into account. And even if the colleagues said no, ECMO is denied because the patient has no prognosis, has too many comorbidities or so, 20% of these survived 90 days. In Germany, we had many eye-openers, let me say. Yeah? If you look at this data from France, if you deny ECMO, 20% survival. In Germany, our survival was 30% overall. Not if we deny ECMO. So we had many eye-openers there, all over the waves. And it was frustrating, let me say that, frustrating for us, that we had a mortality of around about 70%. So that means within the system you have a problem. Even if we look at that and we did some analysis, you see that the patients were not so old. Yeah? The non-survivors had a mean age below 60. You see that if you stratify that by age, and you know that from COVID, that even the best group had a mortality rate of around about 50%. And that especially the 60 to 70 years old had a really worse prognosis in Germany, mortality 75%. That is an eye-opener, but it's only an eye-opener if you draw conclusions out of that. That's very important. We had no difference between male and female. You know, the relation was 2-to-1 between male and female, but if they are on ECMO, it was almost the same behavior. That were not only the data from Germany, but that's also important. You know that women usually can cope with viral infections better than men. Yeah? But if they are sick and if they are on ECMO, there's not really a difference. That's once more, these were also our German data according to what the colleagues from France published, that those one where you start early with ECMO therapy, and keep in mind, ARDS even starts earlier than you start with the ECMO therapy. So if you initiate it within the first 3 days, the patients had the best prognosis. I guess this is one of the key learnings of the pandemic, and I guess we can transfer that also to the other patients. The next very important learning, and that made me thinking a little bit about it, we had a very nice meta-analysis from Dan Brody's group. And there was one point, and if you remember back in the beginning with the first wave, we were very restrictive with steroids. That were our experiences from the flu patients. We had some retrospective analysis in the influenza waves. We had a tendency to a higher mortality. We had some strong waves like 2018 with a number of patients with aspergillus infections or super infections. And that was the reason why we in Germany, and I guess many countries all over the world, said in the beginning, be restrictive with steroids. And then we introduced the steroids. You know that this was one of the key points in the pandemic to reduce mortality in patients on mechanical ventilation. But we didn't discuss much about steroids and ECMO. And this is very interesting. And this was also a further eye-opener for me, that we have to have a close look. Because if you look at the mortality, and you know that you have in the beginning less patients with steroids, and then it was increasing over time, it seems that there is a tendency, not more than that, it's only a tendency, that if you use steroids in patients with ECMO, that it might be that you increase mortality a little bit. That is something I guess we have to keep in mind for the next flu seasons, and I guess it's worthwhile to invest a lot in this research field. It might be that we get more bacterial superinfections, I don't know, with steroids, and it might be that it's for ECMO patients different than for non-ECMO patients. I guess this is something which is very important. The next eye-opener is something which has become the new normal is a little bit too much, but that was really an eye-opener for me. In the beginning or in the last 10 years, we were very restrictive with prone positioning in ECMO patients. And if I think back now 10 years, I do not really know why. Yeah? So this is so the pandemic taught us that proning was one of the key treatments we had, and also in ECMO patients. We discussed that yesterday extensively. From a pathophysiological perspective, you have some arguments for it. The clinical data are a little bit lacking at the moment, but nevertheless, from daily clinical practice, that is something which has become much more normal than it was before. So that led us also to the question, though, pandemic, and within the first waves we had, it was more or less a rescue situation for many patients, but with seeing so many patients, especially so many patients on ECMO, I guess one eye-opener was also that we have to discuss a little bit that ECMO as a respiratory indication is less a rescue therapy, and it needs much more reasonable indication, especially if you look at the mortality data in Germany. And we summarized that. I want to go into detail, but that is something we have to discuss in the future, which are the right indications for that, and it's not the emergency situation, that the indication is it. It might be that it's justified, it might be that you have definitely good arguments against ECMO, and you have many patients between these two, and this is something we also learned during the pandemic, and it was a very important eye-opener for us, especially with these long-term ECMO runs, and some of them are dying after 100 days, and you're always in this conflict that you deny a potentially life-saving therapy, and that you, on the other hand, do not want to avoid prolonged dying. The major point to me, and I stratified that for myself, what was my primary eye-opener, that was the technical and human resources during the pandemic. And that was this is my major slide, and I would like to guide you a little bit through it, because that's how Germany is structured until now, and how we do intensive care practice, and how we do ECMO. These are the number of ICUs with ECMO. This year is 100. That's 100 ICUs here. And in Germany, we have a system, and we are going to extend that in 3 levels. Level 1 means baseline, level 2 a little bit more than that, and level 3 is that what you know as a university hospital or hospital with a size of around about 1,000 beds. That is level 3. And you see that we have many, many, many ICUs in Germany who provide ECMO therapy. Nearly, I would say at the moment, it's somewhere between 300 and 400, and we have 1,700 hospitals. Most of them are small. We have only 425 in the level 2 and 3, and so all of the rest are almost small hospitals. So you see that we had many, many, many ICUs providing ECMO. And if you look at the right-hand side, and we ask, these are data from our ICU registry, we ask how many ECMO devices do you have on your ward? And most of them have 1. That is, to my mind, not state-of-the-art. If the ECMO stop, you can crank a lot afterwards, especially in a pandemic where you don't get devices. And if you look at the left-hand side, how many ECMO cases did you do before pandemic? You see that most of them did 1, 2, 3, 4, 5 cases. And that is my most impressive eye-opener. And we draw some conclusions out of it, and the consequence was that not only to the pandemic, but also to our healthcare structure in Germany, the German government installed a commission, and I'm a member of this commission for German hospital reform. And let me say that is something we now are going to define really level, so 3 levels, and we have, in the future, we will have in Germany minimal quality standards, and that means for the hospital, but also for every department in the hospital. That will become new. It's a very difficult discussion at the moment, but for ECMO therapy, we group the patients. And in the future, from 1,700 hospitals without psychiatry, only 165 will be allowed to do ECMO. I mean, everyone can do ECMO, but you are only reimbursed If you are on this level 3, Lungenersatztherapie means VV ECMO, Herz means VA ECMO, and this will induce, if we have success with our reform and if it goes into a law, and we will try to do that in Germany until the end of the year, we will really change it, and that is a good learning from the pandemic for us. For example, it looks like this. What do you have on level 1, 2, 3? That means which technique do you have? How many nurses do you need? How many doctors do you need? And so on. So this would be a huge step forward for us. So this is my last slide. Sorry, I forgot the conclusion. I guess the major conclusion for me is really look at the human resources more than on the technical resources, and you only can provide something in your country if you have really the human resources for that 24/7. Thank you very much.
Thank you very much, Christian. I think it's really, really important to analyze our outcome, because the technique is consuming a lot of resources, both financial and human resources, and analyzing our outcome is of utmost importance. So, any questions from the audience?
Can I have one? It's great that there's some movement in trying to, what you might call rationalize resources to techniques and things like that. But how much is this a top-down one, the government believing there should be change beneath them, and how much is it a bottom-up movement from the ICU hospital service wanting to do better?
Yeah, the bottom-up movement in the last years in Germany was that everyone saw that we cannot behave like we did in the last years. So this is really bottom-up, and that is in a way common sense. If you are on ICU congresses in Germany, we wanted to restrict something. Even a few years ago, we even wanted to restrict that before, but we had no chance because we as medical societies, we didn't have a great influence. And now in Germany, we have many problems in our hospital system, much different to the UK, but we also have fundamental problems. And in Germany, we are now facing a huge demographic change for the next 10 years. That will be really hard for the hospitals. And therefore, the government decided that they want to have a commission for a complete restructure, because we pay a lot of money into our healthcare system. We are number 2 in the world after the US, and we are increasing from year to year. And they wanted to stop that, and therefore now we have this top-down approach. But we have the problem in Germany that the government can only decide about the reimbursement, but the federal states can decide where a hospital is and if you close a hospital or not. And that is really a huge difficulty in Germany at the moment. We have huge political discussions about that.
Yeah, I think there's quite a few jurisdictions that recognize that type of problem. Thank you very much for your very honest answer.
Thank you.
If I may, I'll have another question, because from your earlier papers analyzing the outcome in Germany way before the pandemic started, I remember an outstandingly high ratio of elderly patients put on ECMO in Germany. Can you please tell us whether this happens in those unexperienced centers, and that you think that this reform you're proposing should change this, perhaps?
Yeah, that's difficult. So I don't know if it's really only in the smaller centers. I guess we have that all over Germany, that elder patients were put on ECMO before the pandemic. In the pandemic, it really went down. So the mean age was a little bit between, let's say, depending on the wave, between 55 and 60 years. So it's better than before. I guess it's very complex. If you have free access to a technique, and if you have enough resources, you use that. And these were the data in Germany before the pandemic began. Now we are going into an area with less resources. We have a clear staff shortening. And if people think we are in a crisis now, the real crisis now starts. Yeah? So with the demographic change, it will be really a big crisis in Germany. And therefore, I guess, at the end, human resources will limit it. That is the key factor in the future. If you don't have a bed, you cannot treat an ECMO patient, and that will put a certain pressure on the patient selection in the future.
Thank you very much. We may clap now.
Thanks.
Lovely. Thank you very much, Christian. We'll now invite Joanne Fowles, the ECMO nurse specialist, ICU nurse specialist from Papworth in Cambridge, to talk to us about how ECMO is now just another support modality.
If I can find my slides. Thank you, whoever did that. Okay, thank you very much for that really lovely introduction. May I introduce Nicoletta? So Nicoletta is a 30-year-old Romanian female who had COVID pneumonia while she was pregnant. At 40 weeks, she had an emergency C-section. Prior to this, she'd been fit and well. This was her second child. She had a 4-year-old little boy at home. Before ECMO, when we went to assess her, she'd been ventilated for 12 days. And her gases, when we arrived, were on 80%, were PO2 of 8, CO2 of 8. She was in the prone position, and she'd been in the prone position intermittently for the previous, 5 days. So while she was with us at Royal Papworth, she was in critical care for 339 days, and she was supported on ECMO for 299 of those days. She required neuromuscular blockade for the first till day 72, and this is for a combination of trying to maintain her PO2 above 6 and her flows on her ECMO to do this. We were able to achieve a VRAS of -1 to 1 on about day 82, and then from then on she had active rehabilitation with our physiotherapy team. She had a lot of input from our speech and language therapy team, and of course the nursing care and medical care at her bedside. She came back to our clinic at 6 months post-decannulation. Her MOCA and HADS were all completely normal. Her diary discussion, well, her diary was very, very long, as you can imagine. And actually, she didn't really want to talk about very much. She had had flashbacks, but she said, oh, I had my flashbacks whilst I was with you, and I talked to you about it then. So she didn't have any need for it. But she really wanted to take it away because she wanted it for when her children were a bit older and for asking questions. So, you know, a novel use for a diary that I'd never come across. Her mobility was limited by her need for oxygen. She was on 2 litres nasal oxygen, but she still managed to walk 139 metres in her 6-minute test and desaturated to 70%. So she has no pain at all, which I think is a real credit, especially to our physiotherapists. I think one of them's here. She didn't have any foot drop. She didn't have any brachial plexus pain. She had nothing at all. She was really, really, really good. Her chest x-ray, she's obviously got some long-term changes, and she had unchanged coarse reticular opacities in both lungs, but they hadn't worsened since her discharge. And functionally, she was really quite cross with her husband because he was really worried. He kept bringing her up from work and it was starting to annoy her, and she felt that she was quite independent. Thank you very much. We didn't only get her off of ECMO, we also taught her English. She had no English before she came to us, and she's now quite fluent. And she was really, really grateful for that. I think she was more grateful than that than anything, because she could now read her books with her son. He was at school and was starting to speak English a lot more. And she's able to take her children in the park and just uses the pushchair for carrying her oxygen cylinders. And you can see there what her quality of life domains are like. So I didn't just think Nicoletta was really nice for you to meet, but I just wanted to ask the question, is this the new normal now? So for those of you who don't know, I'm Jo Fowles. I work at Royal Papworth in Cambridge. I'm a nurse consultant who specialises in ECMO. So Royal Papworth is a specialist cardiothoracic hospital, so a nice niche hospital. We have a 46-bedded adult critical care. We do a lot of cardiothoracic surgery. We do a lot of transplants. We're a UK centre for pulmonary endarterectomy surgery. We do 150 to 200. We're one of the 8 now UK respiratory centres and so we take VV ECMO. We also do a lot of VA ECMO, post-cardiostomy, post-transplantation, and we also do a lot of extracorporeal assist devices because we're a tertiary heart failure unit. So what does the team look like at Royal Papworth? Well, I suspect it looks very much like the teams everywhere. So we're always centred around the patient. We have our medical teams, that's our intensivists, but also it's getting wider and wider. So we call on our ILD teams, our transplant physicians, our microbiology, pathology, our palliative care consultants. And the nurses at the bedside, all our nurses who look after ECMO patients have ECMO training. They're supported by ECMO specialists who are trained and assessed as specialists. Our perfusion team aren't involved in day-to-day care of the ECMO patients, but they're always available and they're really integral, especially to our training program for the ECMO specialists. I pulled the physiotherapist out from the other AHPs because more and more they're a really strong part of our ECMO team and they're involved in their day-to-day management and not just in the late stages of rehabilitation, but also in the early stages of rehabilitation. And then all our other AHPs, our speech and language therapists, therapists, our occupational therapists, our critical care scientists. And all together, we try and be a really cohesive team. So you've all seen slides, various slides looking like this all over the last few days. And it's no surprise, you know, the amount of ECMO that we all have is increasing. And that's reflected in the data at Royal Papworth. So after the surges of ECMO, we're sort of settling down and just gradual increase year on year. But I think what's more interesting to look at is not the number of ECMO they're doing, but how long the runs are. So how many bed days in critical care are taken up by ECMO patients. So at Royal Papworth in 2019, we had our mean days on was 14 days. And then in 2022, it's gone up to 28 days. And I chose 2022 because that was not minimally impacted by COVID patients. But I think our decision-making about when we stop ECMO has definitely been affected by what we saw in COVID. And there's much more of a, let's just go on a little bit more. They may well recover. We've seen this before. And so what we learned in COVID is really, really impacting on our management of all our patients on VV ECMO. And also, it's not quite as big a jump, but still it's a significant jump from an average of 12 days in 2019 to 16 days in 2022. And to just look at how that feels on the floor, so in 2018 we had 894 days in critical care that were occupied, bed days that were occupied by ECMO patients, and that was with 106 patients. And in 2022, we had nearly double that at 1,528 bed days with slightly fewer patients. So we aim to wake all our patients, and the technical challenges and considerations are well documented and have been discussed here at length, and I'm not going to go through those so much today. But having these patients has changed how we work as a team. So the increased number of runs, more runs, awake patients, have impacted in different ways on the team. So on how the other services work, what the risks are, the family, how we manage family, how we work together as a team, and what our perceived outcomes for these patients are. So just going through the other services, so if you've got so many bed days occupied by one specialty, it is going to impact across all the services that we are commissioned to provide and we owe to our other patients. So we've tried to meet that by ring-fencing the cardiac surgery beds. So we have 7 beds that are ring-fenced for cardiac surgery. Patients can go elsewhere, but we're just trying to plan ahead so we can meet those requirements. We collaborate a lot across the national service. So if we've got maybe 5 patients on ECMO and we notice that one of our London partners has maybe got 2, then we will discuss with them and they'll often come in and take a patient for us. So no patient is ever refused ECMO on the VV ECMO service. We really work together to maintain a balance across. One thing COVID did teach us was about working with our critical care networks. And in Great Britain, each region has their own network of all the hospitals and critical cares within that region. And so when a patient is in our intensive care unit, still requires intensive care, but doesn't require the highly specialised services that we have within Royal Papworth. We've got good access and good relationships, good communication with other ITUs, and so we can move patients to a general hospital ITU, which can provide as excellent intensive care as we can without the specialist add-ons. And that allows a flow through of all of the types of specialist patients that we look after. And of course, it impacts on staff experience. We've got so many ECMO at sometimes, staff can be saturated. They can also lose skills on looking after all the other types of patients we have. So I know many units rotate staff, but for us at Royal Papworth, that doesn't really work with that the way we work. So what we have is part of each staff member has got a line manager, and part of our line management is to really work with our staff to make sure that we know what their requirements are, and then we feed that through to the sisters or the lead nurses on the shift who are doing the allocation to ensure that staff are moved around all the types of patients. And then last, it's the ethical issue. You know, is this an appropriate use of resources? And I know this was discussed at length yesterday. So what about the risks? Well, straight off, everyone thinks, oh, well, they're decreased. You're really good. You're doing it a lot. You know, it's like, you know, if you swim every day, you're going to get faster. Well, I'm not entirely sure about that. You know, there is some concerns around complacency. You know, the times, you know, 5-6 years ago, if I went to a bed space where there was an ECMO patient, the nurse would be there, they'd be looking at the patient, they'd be very around that bed space. Now, sometimes when I go, especially an awake patient, the nurse may be like drawn off to do a blood gas for someone else, and the patient is unobserved. So there's that risk of increased risk of inadvertent or incidences. Also, if you do something more, you know, something bad might happen. So, you know, there's an increased likelihood of those rare complications like accidental decannulation. And we have had our first patient decannulate himself. I mean, luckily he was off sweep and he was okay. But, you know, they're the sorts of things we would not have ever had when we were only doing like 50 ECMOs. And of course, there's the unknown. You know, if we're having patients who are on ECMO for 70 or 100 days, you know, how long do the cannula last? You know, will there be complications of the cannula site? You know, how will the patient heal? Most of these patients are on steroids. You know, is there a greater risk of vessel erosion? So does this then extrapolate that there's a greater risk when we're mobilising them? These are all things we don't know yet, so they do all impact on us. But maybe there is that decreased risk because we are more experienced. But I think it's just always about knowing that there is risk and not decreasing your risk-adverse behaviour where it's necessary. So perceived outcomes. And this is quite difficult because we change across patients, we change from patient to patient. But in our experience, the team fall into 3 groups. This isn't about what our outcomes are, this is about what the team are perceiving the outcomes are for particular patients. So the first group is a group that really is carrying that knowledge and that experience we had from COVID. You know, time is a great healer. You know, so 30 days doesn't mean we need to stop because we've seen patients at 60 days they were okay. So there's that group. And then there's the second group who are really aware of the burden of doing long ECMO. So, you know, the burden to the patient and the family due to maybe the low likelihood of them returning to their pre-morbid state. You know, the burden on the community, on their discharge, maybe long-term oxygen and maybe community care. And again, you know, the burden on the health service, is this an appropriate use of resources? And the third group, so the group that basically say why, is this palliative ECMO? You know, and they just, you know, the wondering, why are we doing this when the outcome is inevitable? You know, again, is this the right use of resources? And like I say, even in the space of one patient, myself might move from the, was this the right person to put on? Why are we doing this? Right through to the, actually no, time is a great healer. They've come this far, let's keep going. And it does cause some uncomfortable conversations in the team, but we have to just focus on supporting everyone's opinion and listening to each other. So the family, and we've spoken about family in other sessions through this meeting, and I think everyone's agreed that regular, open and honest conversations are the basis of everything when we're looking with families. With awake patients, managing expectations is probably the hardest thing. It's really difficult to be talking to a family to say, you know, this is end of life when the patient is awake and seemingly recovering. Early intervention of supportive and palliative care, and Harefield gave an excellent presentation on a project that they've done where their supportive and palliative care are involved from day 2, so we'll be stealing that. And I think it just makes such sense. Why didn't we think about it sooner? It's about respecting beliefs as well, involve religious leaders if needed, and I would say in many cases they are. And the financial burden of having a patient on ECMO or a family member on ECMO for a long time, there's always going to be, they're not at work, usually the family can't work, so we get the social work teams involved as soon as we can to support them, and that's one less worry for our team, for our families. And then the team. So I could have just written nothing on this slide except for communication and well-being, because they are the most important things. But when we're looking at managing the care, it's about interprofessional planning. You know, make sure that everyone's in the room. You know, the physiotherapists, the ECMO specialists, the medical teams, the other medical teams that may be involved in the care, to make sure we're all on the same pathway. Or if people want to add and change that pathway, they have an opportunity to put that, you know, their thoughts forward, and that we work together to ensure the best for the patient. So that's regular updating as well, you know, about what we're doing. Provide support for our team. So we spoke on the very first day, we had an excellent plenary session on wellbeing of the team, and that you can't speak about that too much. So it's about providing support, clinical psychology, etc. We've introduced mental health champions in the unit, and so these are our nurses, AHPs, critical care scientists, who have all done some extra training on mental health. So it's about peers helping peers. So you don't need to leave the environment to get the support you need. And education and training. We may be doing a lot of it, but almost more we need to make sure that we're still doing it properly, that we're still doing the assessments, we're still training on our own skills, but also as a skills working together as a team. And having a culture of reflection is really important. We learn from what we didn't do well. That's fairly embedded in all of our governance structures. But what we've really realised is we have to learn from what we've done well and do more of it, and recognise that we've done really well. So to sum up, just key points. We have more ECMO, longer runs, more awake patients. The aim for us all is to reduce the impact on the services, to grow and evolve as teams, and we do that through listening, communicating, supporting each other. Don't be insular, involve other specialists. Manage expectations, not just of the patients and their families, but of the team, especially the more inexperienced members of our teams. And finally, just look after each other. Okay, that's it. Thank you very much. Thank you.
Thank you very much, Jo. I wonder if anyone has any questions before we move on.
Yes, if I'm allowed.
Thanks.
Thank you very much for this very nice talk. Every day in the German newspaper we read the problems of the NHS, that doctors leave the country, that you don't have enough money. That's totally clear. But it's at least in our press we get the impression that the NHS has really a substantial problem. And what do you guess? How will that develop? I mean, does that affect your team, and how is your daily clinical practice, and what do you guess what will happen within the next months or years?
I think that's a pretty good sum up of the NHS, that it has substantial problems, and yes, we do feel it on the floor. So for me as a nurse leader, we have incredible problems in recruiting nurses, especially experienced nurses, and then in retaining them because of the stress of the job. And the major stress isn't about the type of patients we're looking after, it's about having enough nurses at the bedside. So we struggle with that continuously. And the future, I mean, I'm sure a lot of people are aware at the moment there's a lot of industrial action in Great Britain, and the reason for that isn't about more money, it's about more, it's about having the credit for what we're doing so we can attract more people into the workforce, into nursing, into physiotherapy, into medicine. And so I don't know the future. I don't feel very positive about it at the moment.
Should we finish on that for this? Right. It's my great pleasure to introduce Nick Barrett, who you've seen wandering around, chairing meetings, giving eloquent talks. He's the current chair of EuroELSO. He's a critical care consultant at Guy's and Tommy's. And speaking personally, he's a very thoughtful and helpful head of the EuroELSO steering group.
Thank you very much, John. This will not be a particularly erudite talk. It will be substantially less erudite than the two that we've had before, and probably the entire Congress, quite frankly. But it is the last talk, so I think some degree of levity is required. My conflicts. So, Dirk asked me to do this talk, and he left me a little in the dark as to exactly what he would like me to say, until he very helpfully pointed out yesterday morning that he'd already published the paper that he really wanted me to focus on and highlight. And you'll see that it's in the special edition of Perfusion for EuroELSO, and we could probably just leave it there and leave you to Dirk's and colleagues' very thoughtful interpretation of what the future may hold. To look at some of the things, though, we live in we work and live in an increasingly complex environment. We have a huge amount of information available to us from the literature. We've got thousands of publications on ECMO now every year. We have a huge registry in the form of the ELSO registry. We've generated a lot of predictive scoring tools now. And it's becoming increasingly difficult for individuals to keep up. We come to congresses like this, we learn about things, but there's still 4, 5, 6 simultaneous sessions. It's difficult for us to keep on top of everything within our environment. And even down to the individual patient, we've got so many investigations that we can access on a daily basis. So much microbiology, so many new and evolving laboratory investigations, imaging in different imaging regimens. And again, pulling that together, even at the bedside, when you're running a busy intensive care with 10, 15, 20 patients in it, can be very difficult. So how do we bring that data in? How do we know that lactate from 15 minutes ago was an unexpected 6, rather than waiting until we end up discovering it's an unexpected 12, half an hour after that? We also have a huge amount of physiological data about our patients that we're measuring minute to minute, second to second sometimes. We have the integration of ventilation, of advanced physiological monitoring tools, of the observations that we take and monitor and record. And we, as clinicians, our nurses, doctors, AHPs, integrate all those mentally at the bedside hundreds of times a day, often in an imperfect manner, because we can't necessarily recall that the lady in bed 2's bloods from this morning and the lady in bed 3's microbiology from this afternoon, because it all drifts in at different times. On top of that, we have additional devices. So we have, for ECMO, for respiratory ECMO, we have at least 2 devices supporting the lungs. We have an ECMO pump, and we have a ventilator, and we have the native lungs. What are they doing? How much is the native lung doing? How much is the ECMO doing? How do we start to understand that and look at that? Because the reality is, at the moment, our machines don't talk to one another. They don't talk with our EHR. They don't talk with each other. They don't make it easy to integrate. And what we need to start doing is we need to start thinking about the integration of our ECMO, our ventilation, our physiological data, our laboratories, our pre-existing knowledge from the registry, and of course, the literature. We saw during COVID just how rapidly things changed. And it was a full-time job keeping an eye out as to what was the next best guess in terms of therapies. Do we give tocilizumab? Do we give steroids? Do we give remdesivir? And the answer in the afternoon is often different to the answer in the morning. In cardiac, of course, it's even more complex because not only do we have ECMO, a ventilator, we have inotropes, we have impellers, we have balloons, and we're trying to mentally integrate all of those things simultaneously at the bedside. And our tools at the moment, and for our industry folk and our engineers who are still here, our tools are wonderful tools, imperfect, but wonderful tools, but none of them crosstalk. Developing that crosstalk, making life easier for us, will ultimately lead to better patient care, because instead of just looking at ventilator asynchrony, where we're breathing in too long or failing to breathe in at all, or breathing in with too much effort, or breathing out for too long, it falls to the experience of the clinician at the bedside. And we all have different levels of experience, and the most experienced person isn't there all the time. That's not possible. So again, that's that bringing the information together from the disparate sources and through. And of course, these decision-making tools are bringing in the knowledge, the data, the patient-level information. All of that needs to come together to start thinking about decision support tools, where we can define potential actions and look at that patient ventilator, ECMO, inotrope, other techniques, interaction. Of course, we do it on a much simpler scale, simpler level in some areas. So the rise of continuous glucose monitoring has been an enormous boon for patients with diabetes. And then taking that and then turning it into automated insulin pumps. So we're seeing this where we're no longer having the direct involvement. And of course, it's really common in other industries. And we see it in the airline industry in particular. This is, I forgot to put your reference here, Dirk, but this is from Dirk's paper, as is the next slide. So we see it in other industries. It's gradually met. It doesn't necessarily remove the human interaction, but it makes it a lot simpler for people to do their job and to operate safely. And we need to start thinking about how we can do this in relation to ECMO, in relation to the idea of having a digital twin that we can bring everything together and help guide us through the decision making. And maybe it's time to take the experts out of the equation, allow them to leave, and simply replace them with ChatGPT or the next version of artificial intelligence. I don't know, Dirk, was ChatGPT a co-author on your paper? So we could then end up migrating through the hell and purgatory that we're currently in to a sunny beach where we don't have to work and we don't have to sit there and we don't have to worry about our patients because the machines are doing it all. And maybe in the next pandemic, we move from this with countless countless staff trying desperately to keep an eye on everything, to this. Just the patients and the devices. Except it's not really going to quite work, because we still have to go and pick them up. So we still have to have those skills, and we still need to be able to do it in real time. And we still need to do some, is this going to start automatically? We still have to do all the things, the elements of patient care that we do every day and do so rapidly in order to keep our patients alive. And we've heard constantly about the importance of rehabilitation. But it's very staff heavy. And the decision support tools won't be helping us with this. It won't be helping the nursing, it won't be helping the physiotherapy, it won't be helping the occupational therapy and speech therapy, and it won't allow us to take the patients out and sit by the river on a nice, this is obviously a very sunny British afternoon over London. And it doesn't help us get people up and walking around. Because the truth is, no matter how mad our colleagues are, we need them all. We need them to look after the patients. So, will we fly by wire? We may. And I think if our engineers, our data scientists can come together to help us make decisions, I think it will complement the teams. But we can't be replacing the teams. Although, there could well be some cost savings. And then we could potentially use the money for someone we really need. Thank you very much. There might be comments.
Yeah, hi, Andrew Stevens, engineer from Australia. Acknowledging the levity of the talk and putting that aside, if there were two machines that could work together and talk to each other in tandem, that the engineers could automate to some degree to get to work with the ECMO, what would it be? What would be the best thing for the ECMO to talk to?
So, the ventilator.
Yeah,
I
that's
think
what I
that
suspected.
the ventilator-ECMO interaction is absolutely crucial. And we've got so many advanced diagnostic modes and ability to measure physiology through the modern iterations of ventilators. So bringing that together, whether that's work of breathing, whether that's volumetric CO2, whether it's compliance curves, all of that bringing in to better not only protect the lungs, but also understand what's going on with the lungs. And then I think looking at something similar on the cardiac side with sort of cardiac power, looking at the inotropy, bringing that into the equation, along with the ancillary tools, the impellers, the balloons that are so much now part of ECMO.
Thank you.
And perhaps at some point also neuromonitoring, because the brain is probably the last part that we cannot either support or replace in any way.
Shall we fast forward to the closing ceremony?
Is there any other comments on that sort of open sky presentation? Thanks. Right. We will get on with the closing ceremony. Thank you very much, everybody, for your attention, which should be a very few minutes, I think.
Perfect. Thank you all. Thank you all for coming all the way to sunny Lisbon and getting out of, Pele's just gone, told me 1.20 meters of snow the day before he travelled to submerge Sweden. So thank you for coming. Thank you for making the Congress tremendously successful. To all of our speakers, all of our abstract presenters, all of our new young scientists, and all of our attendees, because it's you who make the Congress. And of course, we have to thank our sponsors. They help to keep the Congress running. They've been very good to us for many, many years now, and we're looking forward to a very strong and ongoing relationship with them in future Congresses. It's been quite big. So we've had just under 1,500 delegates on site over the last day and a half from 48 countries. We've had over 200, or nearly 250 abstract submissions in 60 scientific sessions, a whole lot of catering. We've changed the program, and I will be really looking forward to your feedback on it, because we've increased the number of technical sessions substantially. We've seen... Thank you, Professor Ahrens. And as a result, we've got a lot more engineers, we've got biomedical scientists, and I hope you've found that interaction and discussion really valuable to bring together the engineering and clinical teams. We've grown the plenaries. We've got very much the MDT plenaries, and I hope you enjoyed the ethics session and the care for the caregivers session. We've also brought all the oral abstracts into the main session. Some years ago, pre-COVID, we had a separate abstract session. It was well attended by the abstract presenters, but we felt that didn't give them a platform. So we brought those into the main session, and it means that our young and upcoming researchers can present at the same session as some very experienced researchers, and hopefully they gain a lot from that. We've brought a lot of integration between the medical, nursing, and perfusion programs as well, both in adults and pediatrics, and expanded the pediatric side. And we've also started to integrate some of the pediatric and adult sessions in the pre-Congress. We've also continued to focus on practical training, and I think that's grown. We've had some wonderful, really wonderful education corners. Huge amount of simulation is being done. Those sessions are increasingly popular, a very powerful way to gain education. And so I hope that you enjoyed them. Finally, we've embarked upon more joint sessions. So you will have seen sessions with the European Society of Cardiology and Intensive Care Medicines, as well as the International Society for Heart-Lung Transplantation. So the conference has evolved. We need your feedback to continue to evolve, to make the bits that work well work better, and the bits that don't work quite so well that we can fix. And I'll hand over to John, I think.
Just check. We have some awards. Not sure if any of these recipients are here, but if they are, we can come and have the honour of receiving a certificate from Nick. First up might be Rebecca Lewis from London. If she's here, can she stand up and identify herself? You might have to take that back with you, Nick. Yeah, my Portuguese is probably not up to this, but I want to say Rita Araha Silva. Doug? You're very welcome. And finally, again, testing my an array of non-European languages, Myrta Janssens. No? Is Myrta here? Okay. Dirk, we might have to depend on you for contacts. Well, thank you for coming to Lisbon. I'm going to hand over to Konstanty now, who's going to talk to you about next year's fantastic conference.
Thank you, John. Thank you, Nick. I'd like to welcome you all to Krakow next year. It's an exquisite city, top 5 of tourist destinations in Europe, but it's also the city of vibrant academic life with over 200,000 students at 12 universities, with Jagiellonian University being one of the oldest in Europe. So this is the city of long academic tradition, but it's also quite modern. As you can see, one of the first students was Nicolaus Copernicus, but now we have quite modern campus. We also have an exquisite conference center. It's a premium class congress center, very modern and with very good acoustics, which we will try to put in good use, I hope. It's also the city of culture, very famous paintings, including Leonardo da Vinci's Lady with an Ermine. It's a city of long tradition of cohabitation of cultures, including Jewish culture, but also good food. You should try it. You may try it inside or outside. There are plenty of gardens across the old town. Also many attractions outside of the city, including world-famous salt mines of Wieliczka. It's not so far, not as far as you would expect, at least, and you can get there quite easily. And let me share my personal experience regarding EuroELSO and ELSO. I found many friends here, and I found a huge amount of support. That was really great for me because we started from scratch in Poland. So to take care of our patients, we should look after ourselves. We should look after each other, but we also have to look after our families who support them. So please come with your family members. We'll have a sightseeing program, spouses club, run by my wife. Also a breastfeeding room for ladies predominantly. I don't want to exclude anybody, but right. And even an au pair service. I cannot provide all European languages there. Sorry about it. So welcome to Krakow. See you next year.